So I'm going to bring us back to the most important organ again, lungs. Thanks to the organizers for inviting me to speak today. It's a real pleasure to be here. I have some disclosures. Some of these are relevant to the subject of my talk today. As has been clearly shown by the Mount Sinai group, bronchiectasis is a common, unexpected incidental finding in patients undergoing CT screening. Not a surprise. We know that COPD is one of the more common causes of bronchiectasis. In the pivotal study, I would say, again, out of Mount Sinai, about 23% of patients had bronchiectasis. And this is not just an incidental anatomic finding without significance. These patients on average had higher event rates in terms of signs of exacerbations. They had worsened outcomes. Patients with COPD-associated bronchiectasis have increased mortality. This is a real issue and not, again, just an anatomic finding. So it's important. Just to put some perspective here, this is a patient that I saw recently, a new patient referred for cough. I did a CT. This is what I had. So do you think this patient has only been coughing for a few weeks or a few months? Okay. So again, it's not surprising that we're finding these patients incidentally because the clues are being missed. This is a disease or a condition, if you will, that is underdiagnosed and there's delayed diagnosis. These are 5 papers that looked at this from Western Europe, where their healthcare is just as good as ours, just as sophisticated, that found anywhere between 19 years to 4 years delay in diagnosis after symptom onset. Not only that, the market increase in the US of about 8% per year is underdiagnosis, probably in delayed diagnosis, that is being mitigated somewhat by the fact that we're doing more screening and that anyone who walks within a half a block of an ER gets called in for a CT angiogram to the chest to rule out pulmonary embolism. So we're finding it in patients who probably had symptoms and weren't being diagnosed. Obviously, part of that is because the symptoms of bronchiectasis are similar to COPD and asthma, and they're often misdiagnosed. We see that all the time in the office. So the question is, does it matter? Unlike lung cancer, we can't cure it. And even evidence that our treatments improve outcomes or quality of life has been limited, although that is changing. And so therefore, my main goal today is to make the case that finding the bronchiectasis is important. This is a study that, a phase 3 trial of a medication for bronchiectasis that we got published in the New England Journal, so we're very happy about that. It's Bronchiectasis, DPP1 inhibitor, dipeptyl peptidase, activates neutrophil elastase and other serine proteases in the neutrophil while the neutrophil is actually still in the bone marrow. And neutrophil serine proteases, including neutrophil elastase, drive inflammation directly in bronchiectasis. They directly stimulate mucus hypersecretion. They cause epithelial injury. They impair ciliary function. And one of the, at least conceptual beauties of inhibiting DPP1 is you're not taking the neutrophil completely out of the game. The neutrophil is still there, can phagocytize, can reduce neutrophil extracellular traps, release chemokines to attract other inflammatory cells. So you're really sort of a targeted attack on the inflammation from the neutrophil. And this is the result of this phase 3 trial. So there were 2 doses that were studied, and this is looking at exacerbations, placebo. You can see the curves separate, and there's statistically, and I would suggest clinically significant decrease in exacerbation rates with drug at both doses, which is important because exacerbations are certainly linked to increased outcomes down the road, increased frequency of worsened outcomes down the road. as well as loss of lung function. But I got to tell you, most of my patients are not complaining on a regular basis to me of their exacerbations. They're complaining about their chronic cough and sputum every day that embarrasses them, etc. Some of them are also complaining about dyspnea. This was a very exciting finding. And what you can see here is the loss of FEV1, so the loss of lung function, which on average declines more rapidly in these patients than the average patients, and some of them develop respiratory insufficiency. And at the higher dose, you can see that the decline in lung function over time was less than for the lower dose and placebo, and this was statistically significant. And finally, quality of life. Again, one of the biggest, if not biggest, issue. And in both doses, there was a nominally significant improvement in quality of life compared to baseline. So we sort of hit the trifecta with this drug: decreased exacerbations, improvement in slowing down, attenuating the loss of lung function, and improved quality of life. Clearly still unmet need. I don't want to leave you with the impression that this is a miracle cure. Patients still had symptoms, they still had exacerbations, and they were still losing lung function, but at a slower rate. But we have finally the first FDA-approved drug for the treatment, specifically of bronchiectasis. This was approved in middle of August. Now, not all of the data showing improved outcomes with treatment is new. These are older data, 10 years now. Chronic macrolide therapies. Macrolides have intrinsic immunomodulatory effects in addition to killing bugs. And this slide is from a meta-analysis showing improvement in the St. George's Respiratory Questionnaire. So improved quality of life from chronic macrolide therapy in selected patients with bronchiectasis. Also from the same meta-analysis, decreased rate of exacerbations by about 1 per year. In addition, you may be aware, some of you, that inhaled antibiotics are used for bronchiectasis, especially about a third of patients who have chronic Pseudomonas. And none of them are approved because we've had a series of phase 3 trials which didn't meet their endpoint. More accurately, in several of them, one of the studies did and the other didn't for reasons that are complex and we don't need to talk about. But a more recent analysis showed that if you target the patients that have a higher bug load, then you can pick patients that will have improved outcomes with inhaled antibiotics, which makes sense, obviously. The more bacteria to treat, the more likely the antibiotics are going to work. So we finally are starting to develop an armamentarium to improve the life and outcomes of patients with bronchiectasis. So the implications of the delayed diagnosis are delay in addition to the things I mentioned, delay in recognition of underlying causes that are amenable to specific treatment: immunodeficiency, alpha-1 antitrypsin deficiency, CF. I've found several patients in their 60s and 70s over the years, their bronchiectasis was from unsuspected cystic fibrosis. Non-tuberculous mycobacterial infection, most commonly Mycobacterium avium. And then, as I mentioned, delay in treatment for quality of life, exacerbations, and slowing down progression. So I have a question for the audience, and before I make you mull on it, I'll give you the answer from my center. Do we have any idea how often the finding of bronchiectasis that you as radiologists report is acted on when you list it in your screening low-dose CT scan? Because obviously that's a big issue that has been a theme today for many, many conditions. And is there an easy way that we can increase the likelihood of patients receiving appropriate referral and treatment when you note the finding? I suspect very often it's not acted on. As I was thinking about this, I realized that I don't know the answer in my own institution. However, I have a meeting scheduled with our 3 chest radiologists, and we're going to try and tackle this. And also going to have one of my colleagues is going to actually try and find our data to determine how badly, I think is what we're going to find, how badly we're doing. But there's got to be a way to translate now this knowledge into action, the knowledge of the finding of bronchiectasis. Thank you very much.